6 a.m. Two plastic surgeons, same hospital, same medical school class, same 6 years of microsurgery training. One is across the parking lot in an academic operating room, 8 hours into a bilateral breast reconstruction. She's rebuilding both breasts on a cancer patient using the woman's own abdominal tissue, every vessel anastomosed under a microscope. The other is in his cosmetic suite next door, filming a before and after of a rhinoplasty for an Instagram post that will go up at 9 p.m. By morning, he'll have 40 consultation requests in his inbox. Both pass the same boards. One earns $400,000 a year. The other earns over $3 million. Level 1, the medical student. Match day, noon, third Friday in March. You're in your fourth year of medical school. 4 years of undergrad came before this. You owe $220,000 in student loans. Interest started accruing the day each one was disbursed. You're trying to match into integrated plastic surgery, the 6-year residency you can apply to directly from medical school. There are 194 spots in the country this year. 362 people are competing for them. Your application, 35 publications, 6 research experiences, a Step 2 score, around 257. You took a research year between 3rd and 4th year because everyone takes a research year now. The arms race added almost 2 years to your training before residency even started. The NRMP page loads at noon. Your name is on it, or it isn't. If it is, you call your parents. Then you start thinking about the next 6 years. If it isn't, you have options. You can scramble into another specialty in the next 48 hours. You can reapply next cycle and hope another publication round closes the gap. You can walk away from medicine entirely. Most years, applicants with 20 publications and a Step 2 score of 255 still go unmatched. The bar moves every cycle. The classmate sitting next to you matched into dermatology this morning. Her workload over the next 4 years will be lighter than yours by a wide margin. She'll start as a junior, attending 3 years before you do. Her income will land in the same range as yours. She'll be home for dinner most nights of her life. Her residency clinic ends at 5. The partner she lived with through medical school gets used to that schedule in the first 6 months and never has to readjust. By the time you finish your fellowship, she'll have 3 years of attending pay banked, 2 children, and a paid-off practice loan. She picked a different door. You don't know yet that there's a fork inside this specialty. Right now, you just want a name on the page. Level 2, the intern. You're earning $65,000 a year. 3 a.m. burn ICU. A patient came in at midnight from a house fire. 60% total body surface area burns. The fire was in his bedroom. He didn't wake up until smoke was already in the hallway. Both arms have circumferential burns. The dead skin is contracting around the tissue underneath like a tourniquet, cutting off blood flow to his hands. If you don't relieve it in the next hour, he loses the hands. You scrub in for the escharotomy. You make long incisions through the burned skin from the shoulder to the wrist on each arm. The dead skin parts, tissue swells out from underneath. Within a minute, his pulses come back in his fingers. Early excision and grafting in the next 72 hours drops his mortality rate from 45% to 9%. You've read this in textbooks. The first 10 seconds are slow. After that, the hands move on their own. The mandatory plastics conference starts at 6:30 a.m. You haven't slept. You present a case to the chair. Someone asks a question you can't answer. The room waits. You guess wrong. Your stipend, after taxes, about $4,500 a month. Your rent in this city, $1,500. Your loan interest on $200,000 of debt at 6.5%, roughly $1,100 a month. The principal stays where it is. You eat hospital cafeteria food because it's free and faster than cooking. You haven't been to the dentist in 14 months. Your schedule alternates, operating room one day, floor coverage, and consults the day after. The pager fires 40 to 60 times in a 12-hour shift. You learn to triage emergencies from pages that can wait. The skill becomes second nature. A survey of surgical residents, more than half can't keep their own healthcare appointments. 44% gain unwanted weight. 72% say the work is damaging their health. 3 weeks after the night of the escharotomy, the burn patient is back in the unit for dressing changes. 40% of his skin is gone. To the fire, then to the operations that saved him. He recognizes you because you scrubbed in the night he came in. He thanks you. You don't know what to say, so you change the dressing. The dressings come off twice a day for the next 3 months. 60 more months. The next 2 are the hardest. Level 3, the senior resident. You're earning $74,000 a year. 11 p.m., your pager fires. Industrial accident at a metal fabrication plant. 28-year-old machinist, 2 fingers amputated above the base by a hydraulic press. The fingers came in with him on ice. Ischemia time on a digit is around 12 hours. You have 8 left. You prep the operating room yourself. The attending arrives at midnight. The chief is on another free flap 2 doors down. It's just you and the attending. For the next 6 hours, this is your world, the microscope. The vessels in a finger are smaller than a grain of rice. The sutures you tie are smaller than the diameter of a human hair. For 6 hours, no one in the room speaks above a whisper. You forget to be tired. The pain in your back stops registering. Your bladder doesn't either. The only thing in the world is the vessel under the lens. You tie one suture, then another, then another. The attending checks your work. Then he lets you do the next one alone. 5:30 a.m. Both fingers pink up under the lights. The capillary refill comes back. The tendons are repaired and the bones are pinned. He'll need months of hand therapy and may regain 70% of function. He'll grip a wrench again. You go to morning rounds at 7 a.m., 4 hours after closing. Your sister gets married in October. You're on call. You see the photos in a group text 3 weeks later. Your mother sends you a voice memo about how proud she is. You listen to a minute of it on the drive to the operating room. This specialty has a dividing line, microsurgery. Some residents can do anastomosis on a 1 millimeter vessel, and some can't. The ones who can spend their careers rebuilding people who came apart, the ones who can't move toward other work. You don't know yet which one you are. The attending who supervised you tonight earns $550,000 a year. The cosmetic surgeon 2 miles away who didn't take call grossed $2.4 million last year. They went to the same medical school, same residency, different doors after fellowship. Both are still listed as plastic surgeons. 2 more years. Level 4, the junior attending. You're earning between $300,000 and $500,000 a year. 13 years after starting medical school, you finally signed your first attending contract. The W-2 arrives 2 weeks into the job. Your first independent DIEP flap, breast reconstruction using the patient's own abdominal tissue, bilateral after mastectomy. The patient is 41 years old, 2 children. She's been waiting 18 months for this surgery, through chemotherapy, through expanders, through the holding pattern. She picked you because she met you on rounds when she was crying and you sat down. 8 hours under the microscope. The perforators are mapped from imaging. You harvest the abdominal tissue. The chest vessels come up clean. You do the anastomosis yourself this time. No one above you in the operating room. Post-op. Doppler signals strong on both flaps. The flaps are warm and pink. The patient wakes up with breasts made from her own tissue. She cries before anyone speaks. Her husband walks in from the waiting room. He doesn't say anything as he sits down on the floor next to the bed. You go to your office. Your billing report from the past month is on your desk. You spent 8 hours on that DIEP. You read down the reimbursement column. The reimbursement per hour on a bilateral DIEP is among the lowest of any surgery in the country. 8 hours in the operating room paid less than a 2-hour rhinoplasty. Nearly half of breast reconstruction surgeons in the country have cut their DIEP volume. The reimbursement no longer makes financial sense. They're choosing other operations. The wait list for DIEP has gotten longer. You think about the rhinoplasty consult on your schedule for tomorrow morning. Cash pay. No prior authorization. 2 hours. You go home and your partner asks how the day was. You say it was a good day. You don't say anything about the billing report. The next morning, the rhinoplasty consult arrives. She's 28. The procedure has been on her mind for 9 years. Her insurance doesn't pay because her nose is functional. The cash payment, $12,000, clears before she leaves the building. You scrub at 11, By 1 p.m., you're closing. The nasal bones have been broken and reset. The dorsal hump is gone. The tip is rotated 3 millimeters up. 2 hours of operating brought in more revenue than yesterday's 8. Within 5 years, the math will pull you one way or the other. Level 5, the reconstructive attending. You're earning between $500,000 and $700,000 a year. 2 a.m., your pager fires. Your post-op flap from this afternoon is losing Doppler signal. The bedside nurse called the senior resident. The senior called you. You drive back to the hospital. You stand in the doorway of the patient's room for 10 seconds without saying anything because you're calculating ischemia time. Scrubs go on. The operating room opens for an emergency take-back. You re-explore the anastomosis under the microscope. The vein has kinked at the rib. You release it. The flap pinks up at 4:30 a.m. Your op note gets written at 5. You round at 7. The microscope is still your tool. The cases still take 8 hours. The patients are still rebuilding their bodies after cancer or trauma or burns. You stayed because the work is the hardest thing you can do with a scalpel. You stayed because the cases that walk into your clinic are the ones nobody else can take. Your role: microsurgery specialist at an academic center. The lights of the operating room are still on at 3 a.m. most weeks. The flap monitoring app wakes you before your alarm. You went to medical school with 7 other people who matched into integrated plastics. 4 of them are now in cosmetic private practice. One of those 4 matched a year after you. He finished his fellowship 2 years ago. He grossed $2.4 million last year. He posts before and afters on Instagram from his own cosmetic suite. You opened your phone last week and saw one of his posts in your feed. You scrolled past. You made $640,000 last year. The gap between your income and theirs is 3 to 4 times. You've lived with this gap for 10 years. You expect to live with it for 15 more. You don't talk about it with them when you see them at the national meeting. They don't talk about it either. The DIEP on Tuesday went well. The face transplant referral that came in last week is going to be the case of your year. Your residents call you the best teacher in the department. The microscope sits on the cart in the corner of operating room 3. You sit at it again tomorrow. Level 6, cosmetic private practice. Your practice grosses between $1 and $3 million a year. After overhead, you take home between $500,000 and $1.5 million. Tuesday. Your day starts at 7 a.m. with a coffee in your own building. You own the building. The first floor is your accredited office surgical suite. The second floor is your consultation rooms. 7:30 a.m. Facelift, 2.5 hours, $18,000 cash. 11 a.m. Rhinoplasty, 2 hours, $12,000 cash. 2 p.m., 3 consultations back to back. 4:30 p.m., a breast augmentation consultation. The patient books on the spot. 6 p.m. home, dinner at 7, no call. Last year, you grossed $1.1 million. Your overhead, staff, rent, malpractice, marketing, ate $550,000. You took home $550,000. The gross to take home gap is the cost of running a cosmetic practice. Marketing spend, $90,000 a year on PPC ads. Patient coordinator, $85,000 salary. Your aesthetic is recognizable. The kind of nose you build, the kind of augmentation you specialize in. Women in your city see it on someone else and know who did the work. The before and after is the artifact of this work. Patients book consultations after seeing one. You post a rhinoplasty result Tuesday at 9 p.m. and 40 consultation requests come in by Wednesday morning. 3 of them drove 6 hours to meet you. Your schedule fills 3 months out. Most cosmetic practices plateau between 1 and 3 million in revenue. Past 3 million, the practice needs multiple operating rooms, a manager who handles operations when you're scrubbed, and full-time marketing staff. Most surgeons don't want that level of business work. The malpractice exposure is concentrated here. The majority of plastic surgery lawsuits come from elective cosmetic complications, not reconstruction. Mean plaintiff award, over $1 million. Premiums in Florida or California can cross $200,000 a year. October is when you renew. The check is 6 figures. The American Board of Plastic Surgery requires 6 years of training and thousands of cases. The American Board of Cosmetic Surgery requires 1 year of surgical training and a single weekend exam. Both groups call themselves board certified. Patients searching for a cosmetic surgeon on Instagram often can't tell who has which credential. The Brazilian butt lift is the most lethal aesthetic procedure ever documented, roughly one death per several thousand cases. You don't do them. You're home for dinner. Level 7, top of field. Top 1, the brand surgeon. Your Instagram has 1.2 million followers. A patient flies from Dubai for a rhinoplasty revision. $25,000 in cash, paid before she landed. Your practice grossed over $4 million last year. Your personal net worth, if you count the television contracts and the skincare line and the social media monetization, has crossed $50 million. You don't operate every day anymore. You operate 3 days a week. The other 2 days are filming, partnerships, brand work. You hired a junior plastic surgeon to do the consultations and operations you no longer take. Top 2, the academic chair. You run the department at a major medical school. Your salary is between $350,000 and $650,000 a year. You give the keynote at the national meeting. You trained 18 of the people now practicing somewhere in this country. Your income is a fraction of your cosmetic classmates. Hospital committees take 3 afternoons a month. The curriculum gets revised every July. Residency application reading runs until midnight every night in March. The match list comes out, and your name is part of why 6 new residents picked your program over the other 36. In February, you take a senior resident aside. She's choosing between an academic microsurgery position and a cosmetic group practice that's offering double the salary. You don't tell her what to do. You walk her through your 2 paths at year 5 and again today. She takes the academic position when fellowship ends. 12 years later, she runs her own microsurgery program. Top 3, the microsurgery superstar. You did a face transplant last year, one of fewer than 50 performed in the world. 15 hours under the microscope, a surgical team of 22 people. The paper publishes in 2 years. You earn between $600,000 and $1 million a year. The cases that come to your operating room are the ones nobody else can take. You take a referral from across the country once a month. You don't say no. The brand surgeon trained the same 6 years as the microsurgeon. They sat at the same microscope as senior residents. They tied the same 80 sutures. They both still get up at 5:30 a.m. Their billing reports don't look anything alike. Both still call themselves plastic surgeons. A new plastic surgery resident reports for orientation on a Monday in June, day 1. Her badge gets printed at HR, the white coat is in a plastic bag. The locker she's been assigned is on the 2nd floor. She walks past operating room 3, where a bilateral DIEP flap is happening. The cosmetic suite next door is dark. Tuesdays start late. She doesn't know yet which one of those rooms will be hers in 13 years. She doesn't know yet that the microscope at the back of operating room 3 is the artifact of one path. The before and after photo on the cosmetic suite wall is the artifact of the other. She'll start choosing between them as a senior resident. The choice finishes around year 10. She doesn't know yet that the choice happens slowly. By the time she notices it's been made, she'll already be on one side of the hallway. The microscope or the before and after. One of them will be her view by year 10.